since you brought up MRD or minimal residual disease monitoring, just a quick poll of each of you. Are you using it, and at what point would you measure it first? So Natalie, maybe you again.
Boy, have we had a huge debate on this institutionally. I would imagine everybody else had. Right now we're doing it sort of by consensus post-transplant. What we're not doing is using a single result, like Pete says, to sort of determine ending treatment, unless somebody's on a clinical trial. But I think patients are asking for it. I think we're still, like many people, not sure what you do with it. And also maybe, 90 days post-transplant actually isn't the right point to test it. Maybe it's at a year later on. That's a possibility.
Okay, Nupur, what about you?
So I don't routinely do it in my practice, and that's largely because we're not making any treatment-related decisions. The one subset of patients where I do look at MRD is the high-risk patient population. And, there's enough data now. We've been talking about transplant here, but it doesn't matter how you get to that MRD negativity. If you can sustain it with the maintenance that we do in the United States, I do think we can re-ask the question of transplant also now. So as of right now, only high-risk patients.
Tom?
Yeah, so we routinely do it. So when patient achieves a CR, whether it's pre-transplant, 3 months post-transplant, or a year post-transplant, we do MRD testing routinely. That is our clinical practice. We try not to make any clinical decisions based on it, but our goal is to get to MRD negative specifically for the high-risk patients. And for other patients, it's still our hope that we can get there.
So Tom, I'm going to pick on you today. So if you're not making any decisions, why bother doing it? That doesn't make much sense.
Well, I actually think so. In fact, if you have sustained MRD negativity and you have toxicity, so the clinical decisions that we're making, somebody has a year of sustained MRD negativity and then has neuropathy or has GI toxicity, et cetera, it's a lot easier to actually take them off their medicine. So when we look back at our data and say, are we really not making decisions? About a third of the time we are making a change based on the MRD.
So at Mayo, I know that my colleagues were quite insistent that we do MRD testing at day 100. To me, this was totally illogical because it wasn't going to change what we did. But that's what they were doing. I was a bit like you, Natalie. I was kind of waiting till there was a decision point to be made. Like Tom said, maybe they're getting toxicity from maintenance, and you're probably looking for an excuse to take them off if they're MRD negative. Exactly. On a couple of occasions. Or alternatively, if it's a very young patient and they still have quite a high reading despite a normal bone marrow and a negative, blood test, then I think it does beg the question whether one should escalate therapy.